Now, okay. Good afternoon, everyone. My name is Mata Munger. I am the SIBA Clinical Manager for My Brother's Keeper in Jackson, Mississippi, and I am excited to welcome you today to this presentation of Talking Positive. Really, we will be discussing stigmatizing versus affirming language. We want to focus on reframing our language and consider how we communicate with persons living with HIV and the gender diverse community. I am joined today with my partners in Good Stuff, Not Crime, the Denver Prevention Training Center for this interactive discussion. Really, again, focusing on how do we reframe our language when we are dealing with and working with our patients. The hope is that we can teach or provide some information today that is going to increase linkage and retention. We want to be reminded that words do matter. I am joined by some fantastic speakers today, Dr. Alex Mills, who is the co-director for the Center of Gender and Minority Health at the University of Mississippi Medical Center, and Zami Hemingway, who is a capacity building assistance or SIBA assistance manager, gender affirming prevention manager at the Denver Prevention Training Center. This webinar is being sponsored by the CDC 19-1904 capacity building grant. There is going to be time for plenty of questions. I want you all to be engaged. I will be your moderator for today. Again, my name is, for those who are coming in, my name is Mata Munger, and I am the SIBA Clinical Manager for My Brother's Keeper here in Jackson, Mississippi. Please feel free to use the chat. Please note your name and your organization in the chat. At this point, I am going to turn the presentation over to our first speaker, Dr. Mills. It is now your show. Thank you so much.
Fantastic. Thank you, Mata. Really excited to be with everyone here today. Happy Friday. We'll be, again, as you can see, really having a good chance to talk through a lot of things related to language and how important communication is when we're working with people with HIV in the gender diverse community. And I'm going to go ahead and actually these first couple of slides, hand it over to Zami. I'll be your slide advancer, and let me know when you're ready.
Awesome. Thank you so much. Can everyone hear me all right?
We can hear you great.
Awesome. Yes, happy Friday, everyone. Dr. Mills, if you can go ahead and advance the slide, that'd be great. Wonderful. So these are today's learning objectives. We plan to achieve this by beginning our discussion reviewing the prevalence of HIV amongst the transgender and gender diverse population and examining systemic barriers and various forms of discrimination that prevent transgender and gender diverse populations, which includes transgender women, men, and non-binary transgender patients from accessing care, including preventative care such as PrEP. We'll review cases and examples of stigmatizing language and what not to say and provide you with more gender-affirming options. Next slide, please. To get us started, we're going to begin with a language check so that we all have the same understanding of some of the terminology we'll be using throughout today's webinar. Next slide. Thank you. So here we see sexual orientation. When we're discussing sexual orientation, we'll be discussing lesbian, gay, bisexual, queer, pansexual, asexual, and two-spirit. For folks who may not be familiar, a lesbian is someone who is a woman-identified person who's having sexual romantic relationships with another woman-identified person. A gay person is typically someone referring to a gay man or someone, a male or man-identified person who has relationships, romantic or sexual, with other men or male-identified folks. Someone bisexual is someone who has sexual or romantic relationships with folks who identify within the male-female binary or other gender identities. Queer is more of an umbrella term that can at times be pejorative or negative for some generations, but is more of an accepting term now that identifies someone who does not identify as heterosexual. Pansexual is someone who has romantic and sexual relationships with several different gender identities, and asexual is someone who may not identify as having a sexual orientation or a type of sex drive. Two-spirit is a word that we often see for folks who are Native American or indigenous people. This can be a term to identify them for their sexual orientation or gender identity. So it can be used interchangeably for First Nations or Native American people. When we're talking about gender identity, non-binary is someone who does not identify as male or female or within the gender binary. When we're talking about men, we're going to be talking about cisgender men. So folks who are born or assigned male at birth and also identify as men, and trans men are often folks assigned female at birth but identify as men. Cis and trans women. Cis women is a woman or a person assigned female at birth who is also identifies as a woman. A trans woman is someone assigned male at birth but identifies as a woman. Then we'll be talking about gender expression, masculine, feminine, and androgynous. Sex assigned at birth, intersex, assigned female at birth or assigned male at birth. Intersex is someone who who at birth, their gender identity or their designation is what they consider ambiguous. And so, you know, when someone looks at your genitalia when you were born as a child, the doctor says male or female. Someone intersex, the doctor doesn't always know what to classify them. If you have any questions about these definitions or terms throughout this presentation, please drop your question in the chat and we'll be sure to answer it for you. This is some of the common language that we may use throughout this webinar, and some of your clients may use as well to describe their sexual orientation, gender identity, etc. And although this language may be common use, it is always important to use whatever language your client uses to describe themselves. I'm going to go ahead and pass it over to Dr. Mills.
Perfect. Thanks so much, Zami. And I think that last point that he mentioned, you know, about thinking about using the same language as your clients and the people in front of you is really the biggest drive home point that I want to take from this terminology. I know it's a lot of terminology that many of you are aware of, and some of you, maybe some of these terms are new to you. But at the end of the day, it comes down to what's going to be the most appropriate language to use with that person sitting in front of you. Okay, so what I'm going to first start off with is talking a little bit more about, you know, our snapshot of people living with HIV. Many of this information, probably a lot of you are very well aware of, so I won't spend too much on these points so we can get to the rest. But I think it's still important for us to make sure we're all on the same page here. So in terms of looking at our population here in the United States, we have about anywhere from 1.1 to 1.3 million people living with HIV here in the United States. And you'll see here on that right-hand side chart that the majority of those that we see in terms of new diagnoses, again, are typically in our younger age group, about the 25 to getting a little bit into 30 and beyond age range that we're thinking about for new diagnoses. We're definitely moving in the right direction, but still have a lot of progress to go when it comes to working on reducing diagnoses of HIV. It's gone down. However, we know some of that stats we have to be a little bit cognizant of because of COVID and the lack of reliable reporting because, again, of the national emergency and focusing more resources at the time on COVID-19 management and reporting. Majority of those diagnoses that we see that at least are listed as MSM or men who have sex with men. But again, we'll get a little bit more here into what we're talking about with our folks of the transgender and gender diverse community. So in about 2020 in the United States and in 6 dependent areas, about 697 diagnoses of HIV were among transgender and additional persons as well. You'll see that table listed here. The diagnoses of HIV infection among transgender persons accounts for approximately 2% of diagnoses. And transgender women accounted for the highest percentage of diagnoses of HIV infections. So this shows HIV broken down by population and highlighting how intersectionality, a big part of it, plays a role in terms of disparities. We see that when broken down by race and ethnicity for transgender women, Black African American transgender women are disproportionately impacted at about 48%, with Latina, Hispanic transgender women about 32%, and white transgender women at 11%. for transgender men, we see that 28% of diagnoses was amongst Black or African American transgender men, with white transgender men following at 38% and Latino Hispanic transgender men at 25%. And again, like I talked about before, when we think about these particular dates, it's particularly 2020, this data is, again, could be impacted or really was impacted quite a bit about the COVID-19 pandemic. So this may be more of an underestimation or definitely some considerations when we think about these numbers. So you just saw the HIV diagnosis rates amongst trans and gender diverse populations, and you're probably thinking to yourself, well, why are these rates so high? And we see here that about 61% of transgender women engaged in HIV prevention discussions, and that could have been either in a group or an individual discussion outside of your routine HIV testing. However, you see and that 92% of transgender women were aware of HIV PrEP, yet only 32% used PrEP within a 12-month period. So we know that this is due to a lack of access, either due to either the physical location, someone's insurance, or having access to really a gender affirming clinic or medical provider, which is really going to move to this next point. So research had shown that if we do not provide an affirming environment for transgender and non-binary communities, it heavily impacts this population's access to services, whether it is preventative services or care. Much of this affirmation begins with staff. So if trans and gender diverse folks who have had negative interactions with staff when accessing healthcare services, they're more likely to delay or not engage in services at all. Even in the case where the majority of staff are engaging in affirming practices and languages, it only takes one person who's not, and that can be that first interaction the client has with your clinic or organization. And that consequently may be the last interaction that client has with you all. So it's important for everyone to be on the same page. Another piece of affirming interactions that have an impact on prevention is the clinic's ability to provide gender affirming care and therapy. So since the priority of many of the trans and gender diverse community members is receiving gender affirming care, and that therapy affirms who they are, so being able to provide those services with simultaneously HIV care and prevention services, you'll see that you'll have better outcomes with your trans and gender diverse and non-binary patients. They may be more engaged in their care, have less treatment interruptions, and if not in care, they're more likely to start and adhere to treatment. So now that we've taken a look at HIV prevention, let's also think about a chance to think about some of the social determinants of health and health disparities within the trans and gender diverse community. And we'll first start thinking about economic discrimination. So the transgender community do report a higher unemployment rate than their cisgender counterparts, as well as they are more likely to be fired or denied employment altogether due to their gender identity. These forms of discrimination have often led to many trans and gender diverse folks being either overrepresented in more of the underground economy, including sex work, which leads to having a higher risk for HIV, especially if they're not on PrEP. And this you'll see from the bottom here, the 2011 data. We're hoping to get more data here soon from the National Center for Transgender Equity. That data's not out yet, but I anticipate from working with my patients that these numbers have not gotten that much better. When we think about housing insecurity, due to them having that higher unemployment rate, that means there's a greater housing insecurity. So this is taken again from the most recent US transgender survey that we have data on. About 2020 should be out here soon. But we see that about 23% of trans and gender diverse community members experience housing discrimination, and 30% reported homelessness, which is the same in LGBTQ youth. We know insecure housing plays a huge role in health disparities, access to care, and medical adherence. So when transgender and non-binary patients do attempt to be in care, however, they are continued to face discrimination within their healthcare system. Most trans and gender diverse patients have issues with insurance due to trans identity, which may not necessarily align with their sex assigned at birth, or not having health insurance at all due to that unemployment that we talked about in a previous slide. When trans and gender diverse clients do see a provider, many report having to educate their provider. It's about at least 1/3 had a negative experience as well, which takes away from that time to discuss their actual health needs. And lastly, many are not willing to seek care due to that fear of having mistreatment or harassment. And I think this quote here from the In Our Own Voices survey is part of the 2015 transgender survey that I'll read off to you. That when I was in college, I had my health insurance list me as a male, and then they denied coverage for my routine pap smear and a gynecological prescription due to my gender. So as you can imagine, we think about preventative health as well being impacted, all of the consequences that can come from that as well. This slide is highlighting more of the mental health disparities that we see amongst LGBTQ youth specifically. So when it's broken down by gender, we see that about 34% of LGB youth have considered suicide, with 11 attempting. And 52% of transgender and non-binary individuals have considered, with about 21% attempting. And you can just see that visual representation of that, how stark that difference is and how honestly concerning it should be for everyone here on this call. So according to that US transgender survey that we've been talking about, 39% of trans and gender diverse folks specifically experience serious psychological distress. And that's based off of the Kessler-6 psychological distress scale that's used. About 40%, which again, I want to reiterate, 40% have attempted suicide in their lifetime compared to 4.6%. So let that number sink in of how stark of a difference that is and why we're even talking about this in the first place. And this quote here again was taken from that survey, and I think it really does a good job of bringing to point what our concern here is. So I've struggled with depression and anxiety ever since puberty. I failed classes, isolated myself, and considered suicide because of this. A year ago, I felt hopeless and had daily suicidal thought. And today, I've got a plan for the future and haven't had serious suicidal thoughts in months. I firmly believe this is because of my transition. I feel so much more comfortable and happy than I've ever been. I think that really is showing us how important providing gender affirming care can be. And we're going to go through a lot of steps today in terms of communication that play a role in that. Zami, I'll have you take this part over.
Thank you so much, Dr. Mills. So colleagues, we are going to pause here and we really want to hear from you all. You know, we have a question after hearing some of these statistics and hearing the quote. What does this tell you all about the lived experience of transgender and gender diverse populations? Please feel free to unmute and share or place your answer in the chat. So again, what does this tell us about the lived experience of transgender and gender diverse populations? So in the chat, we have mental health support is very important, absolutely. That the lived experience is very difficult. Yes, for some it is, and for many it is very difficult. We also hear that the slides are great and folks are requesting to share them after. It will be a recording, and so we'll make sure that folks get that. What else, colleagues? What else does this tell us about the lived experience? Yeah, it's very isolating. It can be very isolating for many folks. Structural inequities, absolutely. And we providers must customize our care to the individual. Also, the impact of not being seen in the world with how you feel on the inside. Absolutely. Thank you all for those responses. You know, so this truly highlights, and you all began to hit on this truly highlights that from an early age, many members of the transgender and non-binary communities are disproportionately impacted by the prejudices in which the systems and institutions they live in operate, causing disproportionate health disparities. And we see that we have more coming through the chat talking about gender affirming care equals suicide and mental health support and prevention. Absolutely. Lived experience with the intersectional lens means for me understanding the impact that colonization has had on pre-colonial indigenous social systems and gender affirming traditional ways. Absolutely. I love that comment. Let's always talk about liberating our gender experiences. And we have to be extra sensitive and aware of the transgender community's needs. We have to increase transgender community's use of PrEP. and prepare ahead for every single meeting. Thank you all, colleagues. I'm going to pass it over to Dr. Mills to continue for us.
Yeah, thank you. And yeah, these are fantastic comments. And it sounds like enough of these people on this call should maybe help. We could do the whole presentation again with all of your experiences and your thoughts. So really appreciate that. And I think, this is good for us to all be thinking about and discussing that in a group of individuals who already are passionate about this care. So thank you for that. Oops, there we go. All right, so let's see if we can provide some affirming solutions that we can use, particularly related to communication when we're serving the trans, gender diverse, and non-binary community. And I first want to focus on person first versus identity first language. And you can see here on both sides, I'm going to talk about the difference between the two. So identity first is what historically we see quite a bit used, and we're really talking about any either condition or community or person. However, identity first language has this implicit heavy focus on the person's condition, identity, disease state, whatever that may be. And as you can imagine, more stigma then gets focused on that specifier that we've included. Where a person first is really right what it sounds like, that the person comes before that specifier, that adjective, and helps to redirect focus that there's a person in front of us that we're working with and communicating with before any condition, identity is considered, such as having HIV or identifying as trans, gender diverse, or non-binary. So some examples that I think are helpful here to share. So when you're talking about HIV, so instead of saying an HIV positive person, saying a person living with HIV. Instead of, again, when we think about sexual activity, instead of using the term a promiscuous person, saying he, she, they, or whatever pronouns that person uses has multiple partners. Instead of IV drug user, he, she, or they injects drugs. This is also similar, and I talk with my students in my pharmacy program of instead of saying diabetic, you'd say a person with diabetes, right? So it's really can be a universal language change that you can take beyond just our particular topic we're talking about today. Some other examples specific to our folks who are transgender diverse. So again, that identity first option that we want to avoid. So instead of saying a transgender or transgendered, saying more of trans folks, and folks is again more of a inclusive term beyond just labeling it in a more binary way, or saying a person of trans experience or a trans person, which when you think about what I just mentioned, you think, okay, you've put the identity first. However, in many of our more recent or newer generations, that term is still acceptable in terms of empowerment for some really do want to highlight their identity. So instead of biological sex or biological male, biological female, again, assigned male at birth, assigned female at birth, you'll sometimes see abbreviated AMAB or AFAB are some examples of how you can do that specific to the group we're talking about today. Also, some just other ways to be more specific in how we can communicate. So instead of defaulting to someone who's trans or gender diverse with the label of transgender, maybe asking that person how they identify, or using gender diverse, which you'll see that more and more, particularly in literature from what we've used in the past. Instead of saying to somebody, well, what's your real name? Go ahead just asking what is their name, or at the very beginning of that encounter, or introducing yourself to maybe prompt them to introduce themselves, right? It's something that if you think about it, it's not even different than if you're communicating with someone who maybe is cisgender as, hey, my name's Alex, what's your name? Right? It's very simple to make that, and you already are currently doing that. Try not to get paralyzed by that concern. Instead of asking pronouns in a group when one person appears to be trans or gender diverse, again, making sure that we're not making those assumptions, or when asking for pronouns, which I'll get into a little bit here later, of some other reasons why that may be some of the nuance to think about. So instead of saying or using gender terms such as, hey guys and gals, hey ladies, maybe switching to, for me here in the South, y'all works pretty easily, or saying, hey everyone, or colleagues, as Zlatmi has used a couple of times today as an excellent example. or again, we've talked about folks as well. Another one that comes up a bit is asking for preferred pronouns and trying to stay away from that. One of the things that we're thinking about here is that term preferred makes it seem like it's not really a requirement, or that it may just be optional, right? So saying, well, I'd prefer that you call me Alex, but my actual name is Alexander, okay? So you can see that connotation plays a significant role in how we communicate. Instead of maybe mentioning a sex change or sex operation or sex change surgery, it's again that key of affirmation. So gender affirming care or gender confirmation surgery or gender affirming therapy are better terms to use. So why does this matter? Why are we thinking about and spending so much time on person first and affirming language? Well, language matters because when we're affirming to our patients, we can see a significant increase in their health and well-being. And this comes from this 2016 survey. So about 400 trans and gender diverse individuals were surveyed about, one, if their provider was actually culturally inclusive towards them being trans and gender diverse, about their health and their experiencing navigating healthcare. And one of the things that I'll point out to this about these particular providers is they weren't providers who were seeing the patient for gender affirming care. Okay. What we saw is not only were these patients more engaged in their care, and those who are seeing a provider that they identified as using more inclusive language, those that may have had a pre-existing mood disorder, anxiety, depression, whatever that may particularly be, they saw a significant decrease in that group in depression and suicidality, about 50% lower. And again, that's just language from a provider who's not even providing gender affirming care, that specific medical treatment or therapy. So I think that in and of itself is one exceptional way that we can make a change without even having to be prescribing medication. So as we can now continue, we'll talk about more ways that we can be intentional around affirming language or our affirming approach beyond just using language. One of the things that we need to think about for someone who may be self-identifying, or what many in layman terms would say coming out. So coming out is a fluid process, and it can be different based on each individual. And there are different phases that clients can go through when coming out. These can be categorized into three main categories: personal, private, and public. So in terms of the personal category or personal phase, is that individual is still perhaps becoming more self-aware of their sexual orientation and gender identity, or you'll sometimes see it abbreviated as SOGI, and is not out to anyone, okay? Where our private phase is maybe they're starting to now trust more individuals with sharing their SOGI. Particularly, I think about when an example is maybe a social worker, a healthcare professional, maybe a close friend or family member. And then public phase is, again, when they're open with all about their sexual orientation or gender identity. The important thing to remember about these different phases, however, is that it can be fluid in its progression and what phase an individual may be at a particular time. So they may be more in that private phase of their self-identification or being out, within their private healthcare provider's office. But they may not be sharing that with the general public, other healthcare providers that maybe they don't feel that level of affirmation may come from. For an example that I sometimes see with my folks who are trans and gender diverse, and this comes also down to sexual expression or gender expression, I should say, is that they may be in a waiting room and choose when they're in that waiting room to express themselves in the gender that society would consider them to be in, by wearing maybe more masculine clothes because they were assigned male at birth, that they are doing that because they don't want other individuals, or they are afraid of how other individuals may perceive them. So when you are talking with your individuals or your patients or clients that you're seeing, keeping that in mind is that those phases can change, and we can play a role in helping to facilitate that, at least when they're seeing us in whatever environment that may be. Here are also some considerations on patient SOGI disclosure. Again, remember, everyone's different, so it's important to let that patient lead that, and patients can disclose that to a healthcare provider in either an active or a passive way. So when we talk about active, again, that's directly disclosing that information to a provider. And we see from literature that that's more likely to occur when that healthcare professional has been observed to either use inclusive language, appear more knowledgeable in LGBTQ health-related topics, and having strong communication skills. Where more passive would be maybe giving hints. So maybe that provider or that client in front of you mentions that they have a partner, but they're not disclosing pronouns or gender at that particular moment. Maybe a hint that that person is passively trying to share that information. We see this as a little bit more magnified in a challenge for adolescents. Particularly lesbian, gay, and bisexual youth may be less comfortable or not feel as safe disclosing this because of maybe some fears of family discovery. And part of this can go back to our health disparities slides from earlier, of a concern of housing insecurity or repercussions of maybe coming out to a less accepting or affirming family for that instance. Now, as providers, we never know how comfortable or uncomfortable a patient may be when they come in. So it's important to feel comfortable asking SOGI information and to do so in an affirming and non-presumptive, really key way. So here are a few solutions that we provide that help to normalize collecting that information. So one, include it as a routine part of all visits if you're in that setting, but making sure the questions that you're asking a client or a patient are medically necessary or necessary to your particular encounter with that person. Using more non-presumptive questions at first until SOGI becomes more clear. Remember though, again, sexual orientation and gender identity can be independent of each other. So we don't want to make assumptions, particularly when it comes to sexual behavior. And I think this is a great example that we have here of, someone may identify as a transgender female, but they may be romantically attracted to other women and still participate in penetrative intercourse. So again, here absolutely would be an opportunity. If we were making some assumptions, we may miss a chance to discuss and counsel a patient about HIV PrEP. And again, as we've said at the very beginning of this presentation, remember to follow with the patient or the client's lead. So if they're saying it's their lady friend, their guy friend, use that same language with them. That's what they're comfortable using. Go ahead and use that same language. Here's a couple of examples in terms of ways to get this information in practice, both clinically or again, just interacting with them one-on-one in a private setting. I always will start off for me is, prefacing why I'm starting to ask these questions. So for example, I'm going to ask you some questions about your sexual health that I ask all my patients. It's important for me to know these answers so I'll know how to keep you healthy. Or your chart lists you as CYZ, XYZ. What would you like me to call you? Or if I talked about earlier in this presentation, what's your name? Who lives with you? I was asking that to figure out more about potential partners that person may have. And then asking further, how would you describe those relationships with those who live with you? Again, do you have a significant other, partner, or spouse? Again, being non-assumptive in that language. What types of sexual contact do you have with others? And then once you know more information, go ahead and then open it up for that client or that patient to speak with you. So what questions or concerns can I address for you about your sexuality, identity, or sexual desires? And if you're working specifically with gender affirming care for someone who's trans or gender diverse, here are some ways that we can discuss it and keep that focus of the visit respectful. So remember, gender affirmation can be fluid and independent of sexual orientation, and there's really no defined timeline. So this is why we would avoid, in these conversations with someone asking, well, how did you know you were transgender? Instead, because it is fluid, one of the probably more acceptable ways that I use in my practice is I'll ask my patients, tell me about your gender journey. What does your gender journey look like to this point? And then focus on the goals for that person. There's not one set template that we would work through with a patient who identifies as trans or gender diverse and what we would do. So asking, well, what's your goal? What's your number one goal in this journey? And then hitting on some of those specific points. If maybe that person's not entirely sure what you're asking, then we get a little bit more granular with it. We've spoken a lot about language, and yes, we've seen that language is incredibly important, and we know that creating an affirming space for a patient is more than language, but also that physical environment we need to think about. as well, and that begins with staff. And that environment can support or inhibit that disclosure with either a healthcare professional or a member of the care team. So nursing and support staff, for example, are going to be your first point of contact for most patients. So using affirming and culturally competent staff members is going to be critical. There have been some surveys that have looked at this, and in particular with LGBTQ youth, they rank the most important factor for them in terms of a clinic or facility is the nursing and support staff that they meet, the first people that they walk into the door and may greet at that front desk or counter, whatever that may be. So providing training to staff on appropriate language, drafting and discussing a non-discrimination policy, navigating a discussion of pronouns and names may lead to an ease of disclosure and engagement in care. So all these things we need to take into account if we're going to be able to provide culturally competent care and are treating our patients with respect. When it comes to the facility, another thing we need to think about are some of the visual cues. So LGBTQ patients who are still in that more, again, private or protective phase are looking in their environment. They're doing an environment scan to assess for any cues to support that they could feel safe. So some of these, such as transgender flags or publicly posting about your non-discrimination policy, and I have to emphasize publicly is important. It's a very important statement. The LGBTQ patients who are still trying to figure out if that clinic is supportive are going to look for those to see that they're in a safe environment for them to be able to disclose. These are some more system-wide or organizational considerations to have as well. So as I just mentioned earlier, having that development and then public display of a non-discrimination policy that specifically describes sexual orientation and gender identity being a part of that policy. Another option to think about too is formation of LGBTQ employee wellness groups. So ways to further include those who are working in that environment as well. Requiring some sort of continuing education on LGBTQ focused topics, and that could either be more of an informal lunch and learn or actually accredited programming. And then reviewing or even potentially enrolling in what is the Health Equality Index, which comes from the Human Rights Campaign, as an opportunity to develop an actual plan that you can use to identify areas to improve upon at your particular organization to help create a more affirming environment. Now, how you approach data collection in that environment and charting definitely plays a role. And these are some ways to collect data in a more affirming way. So there are standards actually already established and published by the Joint Commission that provide guidance on how we document things related to LGBTQ inclusivity. And those can be forms such that use gender neutral language and allow that individual to self-identify and disclose. Being able to collect that information at very relevant areas such as registration, admission, scheduling, or providing questionnaires or things through an online patient portal, however that works depending on your organization. Some of those things should be collected during that actual clinic encounter, and one of the easiest ways to systematically and consistently do that is to incorporate that into a template, or some EHRs have a smart phrase option. Example was typically used and what the Joint Commission has given examples of is this two-step question related to gender identity. So the first question being, what is your current gender identity? And then what sex were you assigned at birth on your original birth certificate? And I want to point out in number one, that word current is quite purposeful. As we talked about before, gender identity can be fluid. So again, recognizing that for that particular moment when that person is filling out that questionnaire. There are also considerations in that written communication that includes charting, but it's not only just specific to charting. So any written communication to and from the patient, as well as written communication that the patient can have access to, such as like medical records. Remember, these patients and clients can ask to review charts, so we need to be cognizant of using proper names and pronouns. One of the things that comes up when a patient's name is non-preferred name or non-chosen name is being used is called dead naming. And this is important because it can invoke trauma and distress for a person and can jeopardize that relationship that that patient may have or that client may have with who they're working with. Again, remember, preferred we want to take out of that picture, its pronouns are more affirming. And I realize for some folks, or maybe those who are not here on this call, but maybe joining your organization, that may be a struggle if they've not had to think about that before. So one of the always safest ways to do that when you're working on written communication is if it's related to healthcare, writing the patient, or just putting the name, to avoid that dead naming or misgendering. When doing additional preventative care procedures, such as cancer screenings, this is the appropriate time to be asking questions regarding body parts. So for example, asking, do you have a cervix, vagina, penis, etc. But remember, before asking patients about their sex organs, I'd recommend that you ask the patient what language they use for their body parts. If your patient example, or for this example, refers to their sex organ as a front hole, then you would call it a front hole and follow their lead. Again, always following the person's lead. We also want to explain in detail the procedure that's being done before you would begin that exam. And then lastly, thinking about your waiting space. So providing a separate waiting space could be a double-edged sword. Some may feel that it's stigmatizing, and putting them in a different waiting area may also out them. So it's important to ask the patient or client what feels more comfortable for them and see what they would like. For example, do they feel more comfortable in the waiting area with other individuals, or would they like a more expedited being brought back into the exam room or office as soon as possible to wait for their particular healthcare professional that they're going to be meeting with? Also, we have to realize too and discuss what happens if there is an unfriendly encounter and what to do if misgendering happens. We know to err is human, we make mistakes, and they can be unintentionally misgender folks. And there are some ways that we may intentionally harass or bully trans and gender diverse patients, as we saw when we talked about our social determinants of health. But in the case that this happens, we want to address it and correct it promptly. But I would focus on that we don't want to dwell on or prolong it in any way. Once it happens, we want to own our mistake first and acknowledge it and apologize. The patient corrects us, go ahead and sincerely apologize, thank them for being held accountable. And the key here is then to move on. We don't want to be over apologetic or dwell on it and say, oh, I'm so sorry, I can't believe I did that, because then that makes the apology more about us and then not about that particular person or patient. So in the case that maybe your patient uses neopronouns or unfamiliar pronouns, being upfront with the patient too, that you're maybe unfamiliar with those, or this is the first time that you've really used them with another person, and asking them and inviting them to correct you as necessary if they need to. I also want to think about that many of us may be working with students, interns, trainees that are coming into our either healthcare system or clinic. And they may also identify as LGBTQIA or transgender or gender diverse. So we also want to acknowledge, though, that our LGBTQIA students, trainees, and interns also get to come out in their different phases, and they have different levels of exposure or phases of disclosure. So if you're concerned about how to approach that, I think this is a great example. So you'll see here, so maybe in the onboarding process, saying there may be times when I need to follow up with another staff member about a patient or client or project you're assisting with. In an effort to be respectful, how would you like me to refer to you? What would you like me to use certain pronouns, or what name would you like me to use? All right, so we went through a lot of information today, but in summary, thinking about trans and gender diverse folks have experienced discrimination and health disparities, with HIV being no exception. You need to understand the historical challenges that are faced for trans and gender diverse. And starting with that is providing excellent care and growing resiliency in our clients. This really starts with us changing our talking points, but remember, when in doubt, ask, don't make assumptions. And then remember that sexual orientation and gender identity are independent of each other, yet both provide critical information to both celebrate and engage in our patients. And with that, that's all that we have. We'll go ahead and open the floor for questions, Mata.
Thank you so much, Zami and Dr. Mills. This was an amazing presentation. So we have about 15 minutes left for questions. If there are questions, please feel free to either drop them in the chat. We will ask them on your behalf, or you are free to come off mute and ask the question yourself. So this is the time to go ahead and ask questions. So I'm going to go back through the chat in the meantime. And let's see, I saw one that, let's see, we have to be extra sensitive about and aware of the transgender community's needs. We have to increase the transgender community's use of PrEP. So Dr. Mills, any thoughts on increasing the use of PrEP in this community?
Yeah, I mean, I think that's a great question. And I think what it's really a lot of times has been still coming down to is, well, it's a couple of things. One, I think, again, rebuilding, a lot of trust, as we talked about before, is many individuals have a distrust or mistrust of a healthcare professional to even really understand what are their needs. So I think being aware of what those needs are and sharing that with any sort of encounter that you're having, particularly thinking about sexual activity and then talking about PrEP is an excellent place to start with that. I think I was going to say something else with that, and I totally lost my train of thought. I think the other important part too is reframing the discussion and making sure too that education part is important in the fact that many individuals, particularly I think about those assigned female at birth, may still not have a full understanding or risk appraisal that they are at risk for HIV and that they can even take medications. I'll give an example of I have plenty who they right now only see on commercials, the brand name Descovy, and they hear the comment about that it's not been recommended for those assigned female at birth, but then they think that's the only PrEP drug. Right, but we know there is more than that. So I think, again, making sure that we're providing that education is quite important too.
Wonderful. Zami, I'm going to drive the next question to you. Many medical forms have the question sex at birth. What is the best way to ask that question?
Yeah, I thank you. I honestly feel that asking what was your sex assigned at birth is the best way to ask that question. I feel that a lot of folks get a little hesitant and get stuck in, I don't want to offend anyone, but we all are assigned a sex at birth. And so asking that question and doing so more in a confidential and private environment, that's really the important piece, not necessarily how we word that question other than how it's asked, but where is the location that you're asking that question? If it's in a room full of people, that's not the best location, but doing it in a way where confidentiality and privacy can be asked.
Thank you so much. We have another question here. A participant asks, I'm curious as to how you think someone could hold a colleague accountable if they're acting as if they're not supportive of the transgender diverse community. So I'll ask that to both Zami and Dr. Mills. How do you think we can work with our colleagues who may not be as open or as supportive? So Zami, I'll start with you.
But I feel there's a number of ways to really approach the situation. It really depends on your relationship with that colleague. Are you that colleague's, are you all actual peers? Is this colleague or person your supervisor? Are you their supervisor? What is your relationship with them? If it's someone who's your peer and you have a pretty good rapport, then I would recommend taking them aside and say, hey, this is something that we're committed to doing here. And I want to know, how can I support you on supporting our clients, our transgender, non-binary clients better? Like, where are you struggling? And having a real conversation with them. If it has to do with their personal feelings about it, whether it's religious or anything else, then some of it is talking to them about, okay, well, if this is a commitment that we are having at this organization or clinic, how does your commitment to providing the best services possible to all of our clients, how does that come into part with your personal feelings? If they feel that they can't work through it, then maybe the support is, how do we support you in going to an organization that's more in alignment with your personal beliefs? And, so that's the approach that I would recommend is,
Mhm,
really
mhm,
trying to see what's the real issue there and how to support
mhm.
that person and getting in alignment with the organization or being in alignment with the organization that's good for them.
I love that, because I think sometimes we don't just say that, hey, if this is not a good fit for you, let's figure out what's a good fit for you. So I love that. Dr. Mills, any thought?
Yeah, I mean, I think Zami said that fantastically. I 100% agree. And, I think, one of my other thoughts too, when I come at least from the healthcare professional side is, and again, as an educator, when have we ever been taught that our beliefs should indicate and dictate how we provide care, right? So I think that's just an important thing for us to think about in general. The only other comment that I'll add is, outside of having that relationship with that person and how that changes, is I think it's also an important conversation about being a bystander when you see some of this either harassment or sometimes it can still be, of course, unintentional. The only thing I will add beyond pulling that person off to the side is if there was someone else that it was directed towards, following up with that person again in a private location, I wouldn't immediately be like, oh, are you okay? I'm so sorry that happened. Have that conversation somewhere else again to protect that person's privacy, but make sure you close the loop and follow up so that person does know that you are going to be at least an ally in that particular situation. You're paying attention to that.
Awesome. Thank you. Dr. Mills, I'm going to drive this next one directly to you because we're here in Mississippi together. How can you create a more affirming environment for our clients when our paperwork is governed by the state? We can't just change paperwork or systems. That's a good one.
It is a good one. And I think many of us are still looking for the answer to this question ourselves. I think one of the things that we can change if we aren't able to necessarily change the paperwork or the systems is that we can start to change some of the, again, misconceptions and thoughts that already exist that are incorrect about providing affirming care. So again, some advocacy is incredibly important to help to move that needle for us to be able to then change that paperwork if it is governed by our particular state. And I think, still what we can control though, right, is we can control the communication that we have with those individuals. We definitely still have a control over how we advertise that we are a safe environment for those individuals. I think that's the initial place to start, but again, continuing to be that loud advocate is further ways that we can help to eventually, make some changes that allow for us to be able to change every aspect of that system.
Okay, great. Yes, thank you so much for that. Let's see. I was trying to see if there were some more questions. This is being recorded, everyone. Just a note, this is being recorded. If you registered, of course, then we have your email address, so we will be sharing things. I am going to drop my email address in the chat. So if you do want to reach out to me directly in order for more information, I will be more than happy to assist you with that. Let's see, we have about 7 minutes left. Any additional questions? Any additional questions before we wrap up? Any additional questions? And Zami, as well as Dr. Mills, are both dropping their information in the chat. So reach out to us if you need it. Again, any other questions? I want to make sure that we gain as much as we can on this presentation today.
Mata, I don't have a question, but I do want to circle back to the PrEP, how to get more trans and non-binary people engaged with PrEP question. One thing that I really encourage folks to do is also look at ways to create systems that allow gender affirming care and PrEP and ART to be married. And so folks will often say like trans folks aren't engaged in HIV prevention or care, but they want to talk about gender affirming care or access to hormone therapy or surgeries. That's a great way to really start the conversation and get different folks in the trans and non-binary community involved in HIV prevention and care. So there's a lot of misinformation around how does PrEP interact with hormone replacement therapy or hormone therapy, right? And so having that education as well, where if you have someone coming in to talk to you about hormone treatment, to also say, hey, are you interested in PrEP? Do you know how PrEP interacts with HRT? And if you don't, let me give you some information and let me answer some of those questions so that they understand that when you come in to do your blood work for your PrEP, you could also do your blood work for your hormone replacement. And that's a way to really get the community to invest in working with you as well, to remove some of those barriers and allow it to be a one-stop shop for people to get all their needs met.
Awesome. Thank you so much. That was a great point. So thank you for bringing that to fruition for us, Zami. Let's see. We have just a couple more things here. Participant says, I like to see these kind of commitments to have gender inclusive environments embedded. Oh, she was just giving us her information.
Well said.
All right. Wonderful. So this actually, we have about 4 minutes left. I don't want to leave out anyone at all. Any more questions before we close out? Dr. Mills, do you have any closing comments? And then Zami, I'll go to you for any closing comments.
I think I've said a lot of the things here, but I would encourage you to, with this information that you've learned today, those who may not be able to join us, share it, share what you've learned, share it in your words. I think also is very powerful. It's easier to articulate it in your own words to your own community, is another great way for us to continue to spread this beyond just watching a webinar.
Fantastic. Zami, any closing words?
I just want to encourage folks to continue the conversation. So you received a lot of information today and it's a lot to digest, and continue the conversation with your colleagues and come from a place of inquisitiveness. So thinking about that colleague who may not be as affirming as you would like, for example, before we label them as being harmful, maybe go with them and say, hey, what's really going on, right? And come from this place of inquisitiveness so that we can build more allies and accomplices in this work for gender affirming care. And then lastly, really looking at holistic programs for supporting the trans and non-binary community. We do a lot of work around HIV prevention and care and talking about risk and harm reduction and sexual activity. And trans and non-binary folks, we are more than just our sexual activity and our risk for HIV, right? So really gender affirming care is about seeing the whole person and providing services that address the social determinants of health, because that's going to help us optimize our overall health in general. So thank you.
And that is a perfect way to wrap us up. Thank you all so much for joining us today. We appreciate your time. We appreciate your energy. We appreciate your collaborative conversation back and forth on this very important topic. Both the Denver Prevention Training Center and My Brother's Keeper are both CEBA or capacity building providers. We would absolutely love to help you and your organization around these issues, where we can actually do one-on-one capacity building assistance. So please feel free to reach out to either myself. My information was dropped in the chat a few moments ago, or Zami. Reach out to us and we'll let you know how you can set up to do future trainings and technical assistance events like this one. This actually closes out our webinar for today. Thank you again for your time. We appreciate it. You all enjoy your weekend. Have a fabulous, fabulous Friday. Bye-bye. Thank you.
Good job, Dr. Mills and Zami. Great job.
Thank you. Thank you.
Fantastic.
Thank you.
Everybody, we'll do a few moment debrief once everybody exits. And we will go from